So that's just to let you know my message is whatever they need that we can get them, they're going to get so they can provide that support. On the question of the data, absolutely. I want to say there's no question in my mind, and the doctors can speak to this, the driver of this huge uptick in deaths at home is COVID-19. And some people are dying directly of it, and some people are dying indirectly of it, but it is the tragic X factor here. And I want us to count it in the facts we're putting out, not because any of us should be involved in that morbid exercise, but we're forced to because we have to be open with people about what's really going on. So I say, let's state what I think is the truth. Yes, those deaths overwhelmingly, not every one necessarily, but overwhelmingly are because of COVID-19. We should count them towards a total. As quickly as we can get the full facts about them and include them in the demographic data, we must. But we understand there's going to be some challenges and some lag in that just because of the sheer nature of the crisis we're going through.
So, Mr. Mayor, if I can add to that, I think, Laura, the only other thing that I would add to what the mayor laid out, which is absolutely correct, is that we are, first and foremost, focused on ensuring that every New Yorker who dies because of COVID-19 gets counted. I think that as a city, it is part of the healing process to be able to grieve and mourn for all of those that have passed because of COVID-19. And to date, we have only been reporting on people who have had the test. We recognize that there are many people who have not gotten the test and may have, as the mayor said, passed for other reasons, but likely in this period have passed because of COVID-19. So we are committed to ensuring that that data goes up on our website. We anticipate that that will happen in the very near future. And we are committed to also ensuring that we maximize the amount of racial demographic data that we're able to report along with that, though, we are facing some of the same challenges that we have faced with the other data that we are reporting. But the magnitude and the importance of having this data out there so that it becomes part of the healing process for the city once we get to the other side of this horrible outbreak, I think is going to be crucial.
Either doctor, are we good? Or you want to add? Okay, good. Next.
Next, we have Sydney from the Staten Island Advance.
Hey, Mr. Mayor. So Staten Island's political delegation sent you a letter this week calling on you to treat the borough more equally during the coronavirus crisis after you left Staten Island out of the latest surge planning for the public hospitals and the recent announcement of more military personnel. When Staten Island hospitals need these things too, especially at the new South Beach Psychiatric Center, what is your response to the letter? Have you seen it? And do you plan to send Staten Island military medical personnel or any of the free coronavirus testing for healthcare workers? If so, when? And which hotel have you selected on Staten Island to house medical staff and use for more hospital beds?
Okay, on the hotel, Sydney, we'll make sure that's something that's ready to be public, but we do have one hotel ready to go and we'll add as needed. So our team will follow up because we just need to confirm that that's ready to go public. Sydney, your questions always are framed a certain way. You have every right to do that, but I just want to aggressively disagree with the way you're framing it because I honestly don't think it's fair to the 500,000 people of Staten Island. We have been supplying constantly the Staten Island hospitals. I've been constantly talking to Borough President Otto about what Staten Island needs and what it needs. We're getting it. When we talk about ventilators, N95s, surgical masks, everything we provide, what the Staten Island hospitals need, we are sending them. And I understand the history. I've lived it a long time, as you have, of why people on Staten Island, some people are very concerned about making sure Staten Island is not ignored. But I want to protest when actual constant shipments of needed supplies and equipment are going to Staten Island hospitals. That should be reported too, because it's not fair to the people of Staten Island to only show one side of the picture. It's just not. All the efforts being made to support healthcare workers, to support first responders, also are for Staten Island. Everything we're doing is for Staten Island, like all of the 5 boroughs. So the question of the military medical personnel, first of all, what I said was the hospitals bearing the brunt of the crisis in New York City, and is true by the sheer numbers, that some of the very toughest situations, Elmhurst Hospital, Lincoln Hospital, Bellevue Hospital, that the military medical personnel going right into the ICUs and emergency departments was a high, high priority. And I think that was the right priority because those were the places bearing the brunt the most. And we've gotten some of those personnel nowhere near what I'd like to see. I am continuing to push the White House and the Defense Department for many more military medical personnel. And if we get more and more, of course we should be applying them beyond the public hospitals into places like Rumsey, for example. But we don't have that yet. I'll keep fighting for that. The question of the testing, yes, I think this is a very fair question. I did appreciate the point raised by the elected officials from Staten Island that because this is a case where I think the point about not having a public hospital is very fair, where we know that Rumsey in particular handles a big burden, making sure that testing as we have it is available for healthcare workers in Staten Island. I think that's fair. The point, Sydney, and I want this accurately reported, is the as we have it. Right now, we're trying to take what is still too limited an amount of testing, use it to address the most serious cases everywhere, Staten Island and everywhere, save lives, protect healthcare workers, protect first responders. We got to keep building that out, and we're continuing to deepen that. So we're going farther with that than where we were even a week or two ago, but it still has to be within the amount of testing we actually have. So presuming we have it, I would love to see a place like Rumsey and ultimately a place like Staten Island University Hospital have that testing as well. We will work to make that happen. The whole thing hinges on increasing our supply of testing so that we can actually use it the way we want to going forward, not just for the healthcare workers and the first responders, but actually to start to be part of those strategies to get down to low-level transmission and no transmission as well.
Next, we have Ms. Dayuf Campbell. Ms. Dayuf Campbell from
morning.
Africa and Harlem.
Good morning. Can you hear me?
Yes, how you doing?
Fine, thank you. Good morning, Mayor. I have questions about the data that was released yesterday.
Oh, I'm sorry.
Can you hear me?
Yeah, but get close to the phone.
Okay. So I have a question about the data that was released yesterday.
Go ahead.
I have a question about the data.
Yeah, no, I
that
heard
was
you.
released.
I heard you. Go ahead with the question.
Okay, so it seems like it's more complicated than just checking a box to know who is dying of COVID-19. It seems like 37% of death it wasn't clear who those people were. Would you be releasing that data soon? And is it possible to make it mandatory so maybe these type of things will not happen in the future? I had a follow-up question about the juvenile centers. Will the youth be released also? Because I know that you release some people from Rikers Islands, but not from the juvenile centers.
Thank you. On the last part, and one of the doctors, whoever wants to speak to it, will speak to the work to make sure that the information is accurate. But let me just speak to the juvenile facilities. First of all, to compare with the adult facilities, corrections, we're now between 1,100 and 1,200 inmates have been released as part of the humanitarian effort to make sure we are protecting lives of everyone who's in our correction system. And obviously, when we do these releases, we are looking at who can be appropriately released, particularly those who have the most serious health care conditions. We want to be very careful about any human being, even if it's someone who happens to be an inmate who has those serious pre-existing conditions, particularly if they're older. But that is also to protect everyone, to protect our correction officers, to protect the inmates who remain by reducing the population overall in corrections. So that's a substantial number who have been released, and some releases are continuing. In this case, we need the decisions from the DAs or decisions from the state of New York to be able to do additional releases. And we've been pushing that those answers need to happen very, very quickly because this is a crisis here and now, and we need all those other parts of the government that have to make decisions to make them right away. On the juveniles, a very substantial number of juveniles have been released. That has happened. That work has already been done, focused on those who could be released because of lower offenses or those who had any kind of health issue that might be compromising. That has been completed. I want to thank Dr. Perea Hense, and I want to thank the law department played an important role, our Corp Counsel Jim Johnson, our ACS Commissioner David Hansel. They did that work. They completed that work days ago. We can get you the specific numbers on that. Now to the question about how we try and make sure the information is accurate on those who have passed away. Dr. Daskalauskas?
Thank you, sir. So in an effort to get the data around race and ethnicity out, we achieved a threshold of quality data that allowed us to show an initial view of deaths among individuals based on race and ethnicity. We continue to improve our data sources, and you will see that we will have more and more available data. So I think you were referring to the 37% other or incomplete. As we increase our data sources, as we're building this, those data sources will become more and more clear, and there will be fewer individuals who are in that category.
Okay.
Next, we have Aaron from Politico.
Hi, Mr. Mayor. On the testing, when you say we'll need to go to widespread testing, can you clarify what exactly are we missing? Is it kits? Is it the criteria from the federal government? What exactly is lacking there? And are we being as aggressive as we could be with the amount of testing we have now? Because, I've heard you and your administration repeatedly say, doesn't really matter if you get tested, don't even try to get tested unless, you're gravely ill. So can you just sort of explain the divergence between those two messages now that you're saying it'll need to be really widespread before we can start to move on?
Yeah, this is a very good question. I appreciate it because you're raising a couple of different points that I think make the testing discussion a little difficult. So on my colleagues here in a moment, you all will figure out who wants to jump in on, I know Jay Varma's done a lot of work on this, sort of how you get the testing and what you need for the testing. And one of the most frustrating parts, Aaron, I was talking to Jay about this last night, is that I wish it was like one thing. It turns out that, the problem with the testing is you don't just need the kits, you need the reagents. And I wish I could even tell you fully what a reagent was. And there's plastics involved and all sorts of things. I've heard the phrases, but what it adds up to is a lot of component parts to be able to mix the recipe together, or as Jay was saying last night on the phone, if you want a cup of coffee with, cream and sugar, you need the coffee, the water, the cream, the sugar, and the mug to put it in, and we don't have all those pieces, if you will, when it comes to testing to get that cup of coffee with cream and sugar. So the problem is the supply chain is complex, the availability is very uneven. To get to the point you'd like to be at, which is what we wanted on day one is what we want today. Nothing has changed. We would like the ability to test anyone, anytime, for whatever purpose, and know it would be there and it would be quick turnaround. If our entire health team, and I know everyone at Health and Hospitals feels this too, if we had that from day one, this would have been an entirely different reality. If we have that in the future, we will have extraordinary tools to lock down the situation and protect people going forward. But what we've been reduced to, for a lot of time, we had nothing. Then we had very little. You remember in the beginning, we had to wait for stuff to go down to Atlanta and come back, and it took like 3 days, 4 days. We finally got in New York City. We never had enough. It's expanded in New York City. It's still not enough. But at least we've had enough to say we can focus on the people in greatest need, the testing that's actually about saving lives. And I'm going to ask Dr. Varma to jump in on this part to help people understand that part, sort of if you will, the tactical use of testing in saving lives that are in real immediate danger. Clearly, the testing to help healthcare workers and first responders to know when they have to leave work, to know when they can come back to work, to help reassure them so they can stay on the job, which is mission critical for everyone. We're trying now to deepen that and take the testing we do have and get to more and more healthcare workers, more and more first responders, and then ultimately, if we really had a better supply, to start to think about the best ways to use it strategically in communities that need it most. So that we'll get into. Jay can talk about some of that. But the other point, Aaron, you put a lot into one question, and I commend you, is not to see testing as a false idol. Testing is one part of the equation. It's a complex part of the equation itself, but it's only one part of the equation. Because if I tested you today, Aaron, you could be negative, and then if I tested you tomorrow, you could be positive. So the test doesn't tell you everything. It tells you a point in time. The antibody test is interesting, which we still don't have, obviously, in sufficient amounts either. Is a little more interesting on one level that could tell you at least historically if you've been exposed or not, and that's valuable information, but that's not perfect information either. But it's at least a little more a broader time frame. I think the challenge is that testing helps as part of an overall strategy, but it doesn't per se save a life. If the testing is negative today, positive tomorrow, the person positive tomorrow now still has the disease, and our focus is on how can we help them through it. The testing can give people some valuable information for sure, and it can be part of a larger strategy, but it isn't unto itself enough to save the life. And that's where I think some of the confusion comes in. So I've tried as the layman. Let's let Dr. Varma get in, and Dr. Barbeau, anyone can help clarify further.